Okay, I would like to thank Enrico. I can't thank the organizers for inviting me, but I would like to give a thanks to all of you who are here, and especially those persons that are going to be relevant to the topic, Eto Taverna, Marco Maiotti, Raffaello Russo, and Enrico Gevasi. So I'm getting old, and so I can discuss about what I think now about shoulder instability and how I think I treat at least the patients here in Greece. And we know that shoulder is an inherently unstable joint. It's prone to injuries, and it is a joint that dislocates more often. And practically, in the shoulder, there is a compromise between stability and mobility. We know the model of a ball in a small base. And this model talks about why it destabilizes so easily. But it doesn't say all the truth, because the ball on the base is moving all the time. And the base also is moving. It's much more complicated than this static model. So what is shoulder instability? Practically, it's biomechanical dysfunction. It's not that it's a torn ligament or some bone missing. It's the inability of the muscles of the joint to stabilize the joint, to keep the humeral head opposite to the glenoid. And of course, it's a range of presentations, of clinical presentation, and it is a dramatic effect on the life of a usually very young individual. And there is a classification, the Stanmore triangle. And what this triangle says is so important for me, at least, is that we have polar type 1 instability, and this is a traumatic instability to a person that has a normal anatomy. And then there are type 2 and type 3 instabilities, and their trauma becomes less important. And the muscular function and the stabilizing effect of the ligaments gets more important. And especially in polar 3, where we see a person dislocating the shoulder in every motion and many times posteriorly, and can pass unnoticed. So polar number 1, it's mainly trauma, Bankart lesion, plastic deformation of the capsule, bone loss from glenoid. Polar 2 and 3, you must search for muscle patterning, proprioception, muscle coordination. And the classical Bankart lesion, it's have been named many times till now. And Bankart lesion, where the solution, very simply, repair the Bankart lesion. And initially we had either open or arthroscopic, very good results initially. But then this lesion started not to be the only lesion. And as the years of follow-up increasing, the failure rate is increasing also. The redislocation rate increases also. And then the question was why? It was a bad technique or wrong indications? And practically it's both, and technique is improving, and now know that we need many points of stabilization, 3 or 4 anchors, many points of fixation of the labrum to the sutures to the labrum in order to have a strong initial fixation. You can't expect something to heal if it's not fixed strongly and remain in place for a period of time. And then came the wrong indication. And in early 2000, it appeared this article from Burkhardt and De Beer. And all of a sudden, we all start talking about bone loss and the meaning and the importance of bone loss in instability. And this was a really mind-changing article because it came from doctors that were very good arthroscopists, and they had to admit that by arthroscopy they could not solve all the problems. At that time there was no arthroscopic Latarjet. So it started all the discussion about which is the maximum bone loss that we can accept, and it was going like this, and then we discovered the bipolar lesions, the importance of the Hill-Sachs lesion, and then we start saying again that there are other factors, and we came to the IC score. And what is important in the IC score is that trying to do quantitative, what we knew qualitative till now, that it is not only the anatomical lesions that we must take into consideration when we are thinking what we are going to do to a patient with instability. Age, type of activity, level of sport participation, the laxity of the capsule were equally or sometimes more important. So now we say activity level, number of dislocations, age of first dislocation, shoulder laxity, bone defects, if it's a revision surgery that we have to keep in mind when we decide what to do, a soft tissue or a bone procedure. And of course, we must not forget conservative treatment, because muscle training, re-education, proprioceptive skills are equally, and sometimes more important in the stabilization of the shoulder. For anyone who sees a shoulder joint knows that these thin ligaments that are in front, it's impossible to keep the humeral head in place when we throw something. What keeps the humeral head in place is the muscles that are around the ligaments, and they are getting information from the ligament of what is the relation between the position of the humeral head and the position of the glenoid, and this makes them to react accordingly in order to stabilize the joint. So physiotherapy, rehabilitation program after the operation or without an operation is very important. And so now we have many soft tissue procedures. Bankard repair, remplissage came from Gene Wolfe during the early 2000s. And then now have ASA, DAS, many techniques to increase the tension of the capsule, because repair the labrium, but we have also to take into consideration the tension of the capsule and the quality of the capsule. And then, of course, there are bony procedures, Latarze, and arthroscopic bone block. And when we are deciding to do a soft tissue procedure, we have to do in a modern way, in a way that nowadays we think it's a good way. And of course, now we can combine it with remplissage, or we published our results. We had a failure rate of 6% in 8 years. Or with ASA, this is something that we are doing now. We are repairing the Bankard, and we are combining it with ASA or ASA and remplissage. Why we are doing it? Because we want to be certain that we have good tension of the system first. Second, it's so easy to do. It's just 5 minutes more in the operating time. And now it's thus also another type of operation that we can use in order to increase, again, the tension and the quality in the system, in the soft tissue envelope of the shoulder. And of course, glenoid bone loss, 20% glenoid bone, then Bankard repair. Soft tissue operations in general are not appropriate, and then we go to bone procedures. And the classical bone procedure, especially in Western Europe, arthroscopic Latarze, and open or arthroscopic Latarze, a great operation, and so good operation that sometimes say, why not do only this operation? Excellent, we can expect excellent results, but we can expect excellent results in very good hands, in very good surgeons who have a very good experience of many cases. Otherwise, complications are around, and it's not only the number of complications, it's the severity of the complications that makes this not a benign procedure. And then comes the idea, how can improve bone procedures, keeping them equally effective to letter Z and trying to have a safer procedure. And then it's the Denhibinet, one of the oldest also surgical intervention. And it has a long follow-up, and it can be implant-free. It can perform all arthroscopic now. And from all those available now bone procedures, we start doing the bone block procedure as it was described and proposed by Ettore Taverna, making some modifications, use the lateral instead of the beach chair position. And what we did from the beginning, it was to combine the procedure, the bone block procedure, with refixation of the labrum and the capsule back to its position and trying to reinforce this repair. And we use, most of the time, we use autograft from the iliac crest. Of course, we know the donor site morbidity, but in our hands and in many other fellow colleagues, we discuss, it's something that lasts for 2 to 3 weeks, and then practically there is no problem, even in very active individuals like runners, football players, and in time. And what this technique also can be combined very easily with ASA. Already Raffaello Russo talked about this. We do it many times. And also we can use alternative bone source, autograft from the clavicle, distal clavicle. Just Paul just talked about this. Or Philippe Morodo used a part of bone from the acromion spine. Although these are available autographs, in my mind, I would not like to put another trauma to an already traumatized shoulder. And there is alternative source also, xenograft and allograft. And most of the cases that we have performed are with autograft, very few are with xenografts and allografts. We didn't show any difference in the result. The preparation is known. What is very interesting with this technique is that we use a posterior guide, as it was shown already. That means we are away from the neurovascular structures. We use the classical portals. We enter the bone block through the interval. It's things that we are all very familiar with. And of course, there is no violation of the subscapularis. We avoid the screws, and the anterior anatomy of the shoulder is not disturbed. And if it happens to have a revision, it's much easier to have a revision of this procedure than letter Z. And we published the first results. When we were checking to see the patient, we saw that having a safe bone procedure made it a procedure that we use even with smaller bone defects. It was not now a procedure of increasing the bone, repairing the bone loss, but it was a procedure that was augmenting the repair of the soft tissues by the bone block. And radiographic images they are made, and we had a second look arthroscopy in many patients, and what we saw was that this is a second look arthroscopy with nanoscope, needle arthroscopy, and what we saw that the healing of the capsule was very good, and first, and second, the articular surfaces were also not disturbed by the operation. And of course, there are other options, and arthroscopic lateral Z is the other option for arthroscopic bone procedures. And Laurent Lafosse is the originator using the 2 screws model, and then Pascal Boileau with 1 button, and then Philippe Valedy with 2 buttons. Practically, the same thought is behind this also, how we could make a very effective procedure safer and easier to perform. So what we expect now, that by increasing the stabilizing factors, we are going to have a lower recurrence rate. And this is true, and this is a well-known article from Philippe Morode, who showed that there is similar results between a bone block procedure, an open J graft procedure, and the Latarze procedure. Then, when to do Latarze? And my thought is to use it when we have a failure of edenhibinet instead of vice versa, because this is makes much more sense to me than the opposite, performing a Latarze and then, if this fails, performing a bone block procedure. The problem is that if you limit the indications for Latarze, you limit also the experience of Latarze. That is making more difficult to use it. So we had one case that one of the bone block procedures failed, and in this case we redid a bone block procedure again. So in our series from 2015 to 2021, we had 256 patients. They are patients that are coming to our practice. They are not all of them athletes. 20% of them was overhead or contact sports. And what we did, we saw that 60% of them, we performed a soft tissue procedure, 40% of them, we performed a bony procedure. And what was interesting, bony procedure, less sport activity than in soft tissue procedures. And I was trying to explain to myself why this happened. And it was very simple. We were operating athletes in the first dislocation, so it was much more common to perform a soft tissue procedure than a bony procedure. We used bony procedures for more dislocations. Usually these patients had abandoned athletics due to the fact that they were dislocating the shoulder or they had a lower athletic activity. And that is well seen in the second chart, where you can see that in bone procedure you have 35% with 42% with more than 10 dislocations, when in the soft tissue procedures, most of them are 1 to 2 dislocations. Recurrence. We had one case of bone procedure that bone block procedure that we had to revise due to redislocations, and we have 5 cases in the soft tissue procedure. So now, in a bigger number of patients, till 23, till last December, we see that the analogy between soft tissue and bone procedures remain the same in our practice. And the most important thing, now we combine all and more the bone procedures with ASA or remplissage or capsular repair. So all the scores are improved, and what we see is that with bone procedures, patients are coming to a lower participation in sports and have a better satisfaction. And this also can be explained for the fact that they have a worse problem. Usually we perform a soft tissue procedure to a person that has a normal life, athletic life, has one first dislocation, and gets back to his previous level of activity. While we operate with bone procedures, patients that they have lowered the level of athletic activity due to the fact that they are dislocating, and then they are returning to a higher level and they are more satisfied. So now we know bone loss is a major factor of failure of soft tissue procedures. We have unacceptable high failure rates. We have a great bone loss, and there are many procedures now that are described, bone procedures that are described that we can use, And while initially these were procedures that we used in order to restore the bone loss, now are procedures that we are performing in more active and more patients with more dislocation, not even if the bone loss is small. So, in conclusion, what is nice is that now treatment of shoulder instability is a staged procedure. We can start without bone loss and perform an arthroscopic bunker repair. But if we are not satisfied with the quality of the capsule, we can reinforce the anterior capsule either with ASA or Latarze is reinforcing also the anterior capsule, or DAS. If there is a problem with the posterior capsule, we have a very loose posterior capsule. Remplissage is not only the filler of a defect on the human head, it also reduces very effectively the volume of the posterior capsule. And if we have substantial bone loss, we can augment the glenoid with a arthroscopic bone block or a Latarze procedure. So we can start and decide during the operation what we can do. Not forgetting that all these are happening to patients that they are not only anatomic lesions. The activity level, the type of the patient, the laxity of the patient are equally important in our decisions. Thank you for your attention.
So this is a magistralis lecture. I don't know if in a magistralis lecture the questions are allowed.
Probably all these things have been already said, so it's just a repetition of how we are changing what we are doing depending on the procedures that are available. And there are two things that are driving what we are doing. First, to have effective procedures, then to have technically easy procedures, then to have procedures with low risk of complication, then procedures that if we have a complication, to be easy to repair, to solve the problem. And this is behind all our minds when we see a patient. I think it's behind the minds of all of us. When you treat a patient that it is 20 years old, 18 years old, 16 years old, and you think that what you have to do must at least not make the patient worse.
At the conclusion of your speech, you told that the remplissage causes or promotes a posterior reduction of the capsular volume. Yeah. And I mean that remplissage for anterior instability is promoting a posterior retention of the loose capsule, flimsy posterior capsule. Yeah. That is very important. Okay. So we now give the podium to the other presenters.